Welcome back to Infection Prevention, Not for the Faint of Heart. This podcast tackles the toughest topics in infection control with wit, wisdom, and maybe a little bit of hand sanitizer. I'm one of your co-hosts, Jessie.
And I'm Nikki, your infection prevention hype woman, and we are ready to dive into the fascinating and, if we're going to be honest, slightly terrifying world of Candida Auris. And today we have a special bonus episode analyzing an expanded admission screening protocol for this superbug at a New York City hospital. And let me tell you, we have got an all-star team joining us today. First up, we've got Dr. Waleed Javaid. He's kind of a big deal. He's a professor of medicine at the Icahn School of Medicine at Mount Sinai, hospital epidemiologist, and director of infection prevention and control. He's been leading the charge against healthcare-associated infections for over a decade. If infection prevention had an Avengers team, he would definitely be in it.
Yes, and next, we've got Aaron Cheng, an infection surveillance officer at Mount Sinai, Brooklyn. Aaron's got serious public health street cred with over 8 years of experience in research and fieldwork. He's tackled everything from nutrition programs to hospital quality improvement and just earned his CIC in 2024. Yay. So basically, he's the infection preventionist of the future.
Go Aaron. And last but certainly not least, we have Karen Brody. Karen is the Associate Director of Infection Prevention at Mount Sinai Hospital. But let's be real, she has been everywhere. She's been a nurse since 2008. She's worked in acute care, long-term care, behavioral health, and even dialysis units. She's also about to take the reins as the president of the Greater New York APIC chapter in 2026. So if anyone knows infection prevention inside and out, it is Karen. Welcome to the show, everyone.
Can't wait to chat with everyone today.
Yay. All right. So, Jess.
Yeah.
Let's
dive right in.
Okay.
So, Dr. Javaid, let's dive right in. What initially sparked this research, and how did you design this study to tackle the Candida auris challenges head on?
Thank you so much for the wonderful introduction, and also thank you so much for the great question that about the Candida auris and our study. We have seen Candida auris in New York City for almost a decade now, and around that time, the hospital has been implementing a lot of measures to control the spread of Candida auris itself. We have published in the past, but very recently we actually started seeing Candida auris cases, and the real big prompt was a clinical case that was discovered. And when we reviewed the chart, we saw the patient had been in our hospital for a extended period of time, but also was in a nursing home. And even though we were doing some surveillance screening in the past of some targeted patients, we missed this specific patient. Upon review from the past cases and this specific case that actually is highlighted in our paper as well, we kind of determined that maybe we need to expand our surveillance testing and simplify it to all patients coming from skilled nursing facilities. And that kind of resulted in our expanded protocol. And we looked at the time before the intervention, a year before the intervention, and year after the intervention to see if we had any clinical cases. So clinical cases is what we define as people with clinical samples, not surveillance samples, positive for Candida auris. And before the study was implemented, we had several. And after the implementation of the surveillance system or a surveillance technique, that we were able to limit that or eliminate that completely.
That's fascinating. So can you tell us a little bit about the screening methods that were used? Did you use swabs, blood tests, crystal balls? What was the process?
We tried crystal balls. That didn't work.
Send them back. They're faulty.
So I actually literally have a crystal ball on my desk. That didn't work. So we were using actually swabs. When we implemented this change, we were doing culture-based method or chromogar-based method, we were doing swabs with nasal and groin and axilla swabs for surveillance of patients. And the method in itself didn't change before and after the implementation of expanded screening process. And we were like the other thing we did was we kind of classified people that we were screening in two categories: high risk and low risk. High risk category included patients with trach and vent, and the low risk were all other nursing home patients. And the reason we classified is to actually classify who we are going to isolate even before the results are back and who we are not going to isolate. Because otherwise, if we isolated that in this particular hospital, we had a lot of nursing home patients coming in, and if we isolated everyone, we would not have rooms to place our patients. So I think there was a lot of thought based on who we were going to isolate, and I think that was part of our success with this study.
So, talk a little more about the proper specimen collection while we're on that subject.
Sure, I think I can jump in and talk about this part. So with this, we educated the nurses were already educated on how to collect the swabs in the ER. So we expanded that education to the nurses throughout the facility so that the swabs could be collected on every unit. Ideally, we did want them to be collected in the ER as soon as we knew the patient was going to be admitted. But sometimes there were cases where it was missed then because they might not have known they were being admitted, or there wasn't enough time or privacy to collect the specimens in that setting. So then the specimens were collected as soon as possible when they got to the unit. And with the specimens, there's skin swabs. And as he said, they were from one specimen was from both nares, and the other was from both axilla and both sides of the groin, or inguinal folds, which we'd like to call it in a nicer term. And the lab has quality checks in place that would reject specimens if the integrity of the specimen was questionable, such as if there was improper labeling or it was a poor quality sample.
So you all do nares as well. So the screening that I know of for Candida auris really was just axillary and inguinal folds, or is the nice one, or as one of my administrators calls it, the groin. And I'm like, well, that's so Kentucky, the groin.
Yeah.
So let's talk about the why. So why would a hospital choose to implement C. auris screening? Like, what's the big deal about early detection? Is it about preventing full-blown outbreak, or are there other benefits?
I think you got that one right on the nose, actually. So when we're looking at why we'd want to implement C. auris screening, I think the first thing that we need to look at is a few factors. I think the first one is really looking at what is your community prevalence of C. auris? Do we know if there's any cases? Have we identified cases at the local level? Do other facilities in your area have it? And kind of looking at what your state or provincial health authorities, what guidance do they have right now out on C. auris screening, and if they've identified any issues coming up. For screening, basically, we can identify colonization cases because these patients aren't symptomatic, but they are able to spread C. auris. So we do want to keep that from happening, prevent these outbreaks, and not have any nosocomial infections. So I think looking at the benefits of this, there's many benefits. The key one is preventing these outbreaks, but identifying these patients early on in like a patient's admission, we can really create a baseline so we're able to understand that at least at this point in time, we haven't seen any positive results. If the patient returns to us down the line, at least we know we've tested them at some point and we're able to go from there. If we identify these patients a little bit earlier in their stay, it really does help in terms for infection preventionists. We can go back and trace the patient's movements, any procedures that they might have, equipment that may have been used. So we can go back and do a really thorough cleaning job and test any roommates potentially that this patient might have been in contact with.
So this is kind of a two-parter question, but the study specifically highlighted tracheostomy and ventilator-dependent patients as a high-risk patient group. So first part is, why were those groups sort of singled out as high risk? And then also, how did patients from skilled nursing facilities fit into this risk assessment? Were they considered sort of the patient zero suspects?
Sure. I can answer that question. And that's a great question. So the presence of mechanical ventilation has always been a risk factor for CRS, and it actually is a high risk factor for CRS. It's been identified by the CDC, and also there's several studies prior to ours that coincide with this evidence that the mechanical ventilation and then in turn tracheostomies, which are usually for patients who've had mechanical ventilation for a long time. So that's why that was part of that. And also, these patients, besides just having that, they also have multiple healthcare facility encounters and long lengths of stay, which increases their likelihood of exposure at some point to Candida auris, as well as, but the potential for getting certain medications or anything that could lead to resistance like this. And the acuity of their illness also makes them very susceptible to resistant organisms like Candida auris. The other category, the low risk patients, which would be patients from skilled nursing facilities without trach or vent, that's actually the part that we added to because we wanted to explore more. Many prior studies and most screening has been on patients in long-term care vent units or point prevalence studies or patients in intensive care units. So we added in the skilled nursing facilities all patients just to not miss any of those other patients. And because of our experience of finding patients like that in the past that had been exposed. And, these skilled nursing facilities they're not an island, they're not alone. So they do encounter these other patients that are on mechanical ventilation. And also if they're in a skilled nursing facility, they probably potentially came from a hospital before where they could have been exposed to other patients that could have been colonized with this. So that's the part that we added just to explore more to see what's in these low risk patients. And that was the surprising thing that we did find that although the percentage of patients positive from that low risk population is much lower, it's still there, so it's still something that we want to know about.
Yeah, definitely want to know about it. So how were you able to identify and manage these high-risk patients within your hospital setting?
Okay, that's another good question. Sorry, I feel like I jumping in again. So we actually really had a great partnership with our ER leadership and our ED team. And they were already testing the patients from the high-risk facilities and isolating them as soon as possible. So we added some screening to the triage process that actually asked if they were from a skilled nursing facility. And if they were, then it triggered them to test the patients. They did their best with that, and most of the testing was initiated there and from their triage. But sometimes it could have been missed because sometimes patients don't mention it, or the transfer forms are incomplete, and then the patient reaches the floor and they haven't been tested. So then we used data mining software with keywords such as trach, vent, skilled nursing facility, nursing home, in order to capture those other patients that could have been missed in the initial screening process. And then we used our Epic chat to reach out to providers to ask them to initiate the screening process as soon as possible once the patients were admitted, if they were missed in the ER.
And so having, the opportunity to find more of these patients, were you seeing that your personal protective equipment was flying off the shelves? Was that an issue at all?
PPE wasn't an issue for us. We were able to keep adequate supplies. It was just maintaining, restocking it onto the units to make sure that it's closer and more convenient outside these rooms in the hospital that these high-risk patients were at. So we're able to keep things safe.
Yeah, I can actually add to that too. So PPE also wasn't an issue and doesn't continue to be one because we don't use contact precautions for patients who we are testing due to low risk. I mean, obviously, when we find out that they're positive, we do. But if it's just routine low risk testing, then additional gowns are not needed. And we do, when they are positive in our small community hospital there, we're able to put the positive patients on one unit. So cohort them together and make sure that there was extra PPE delivered to that unit while we were caring for those patients.
So it sounds like did you all have a special CRS ward? I mean, I know that isolating these patients can be logistical nightmares.
Yeah, you definitely have highlighted something that we worked on. I think for us here at Mount Sinai, Brooklyn, we do have kind of a designated unit that we look towards to place patients that are positive for C. auris, as well as any of our high risk patients while they were pending their test results. So it does create some logistical challenges in terms of moving patients to ensure that we have those rooms open, but we work really closely with that specific unit as well as our bed management team at the health system to ensure that patient flow moves relatively well throughout this.
So yeah, there's a lot of creativity with bed assignments, I'm sure, and a lot of challenges with patient placements. And I've actually personally been in a situation where Candida auris was identified in a hospital, and it was one of the most challenging infection prevention experiences of my entire career. It just reinforced why infection prevention is so critical. So, when C. auris enters your facility, it is not just a clinical problem. It is an emotional and logistical nightmare because you're in 24/7 crisis mode all of a sudden, trying to contain something that is already ahead of you. So, Dr. Javaid, from your perspective, what were some of the most challenging aspects of implementing all of it? Containment measures, screening, all of
I
it.
think, thank you so much, Nikki. I think you're hitting the problem on the head in terms of I think it's a logistical challenge, but I think we were able to, with the collaboration with the entire facility, from the president of the hospital down to our ED leadership, to everybody, EDS, everybody was hands-on involved. And it's almost like a team sport. As you know, the infection prevention is a team sport. It cannot be done in silo by only IPs or infection preventionists. We all kind of came together to kind of implement this study. We had to explain, we met with everybody, we had to explain exactly what we are doing, and why this would be a preemptive strike, if you were to kind of detect cases beforehand. And I think once everybody got on board, we had to do what I would say just-in-time training or just-in-time education on, okay, why are we not isolating this person even though we are doing a screening test, versus before we were doing isolation with all screening tests. That's one thing. And second thing, Nikki, that you had mentioned, which is the biggest issue we were facing in this particular hospital, was that when we had clinical cases identified, then we had to do a retrospective analysis of the entire unit. And that really required a lot of testing of a lot of patients, a lot of isolation, blocking a lot of rooms, causing a lot of distress patients, both, but also in staff who were getting worried that, hey, am I getting exposed to a bug that is so difficult to treat and so dangerous that we are isolating everyone? It was so with that background, we were able to, as Aaron mentioned, train some specific staff in one unit where we kind of cohorted majority of our patients, but also educated everybody else that, hey, because we're expanding, you might get a patient who's just on screening and not necessarily positive on this unit. So it did help to kind of preemptively educate everyone. And then the other thing about this is that for CRS, if anybody tests positive for CRS, the isolation is pretty much lifelong.
Yes. Yeah.
And there's no there are some methods, CDC describes some methods of clearing, but there's no concrete evidence that CRS leaves or colonization of CRS kind of completely gets eliminated. And with that in the background, we kind of were able to kind of almost preemptively both identify this fear, but also address hey, we can isolate that. Okay, this isolation will be extended throughout the hospitalization and all the recurrent hospitalizations. So we didn't retest people.
You kind of touched on something too. There's not a whole lot of literature on Candida auris. We don't have the evidence like we do on a lot of other superbugs on how to manage that. So yeah, once somebody has that Candida auris tag, they're kind of in isolation for life. And just to hit on some other stuff you said, educating all of the staff on what Candida auris is and how you prevent it and what these precautions and screenings are for. And the retrospective reviews, it's not just on the patients. There's a lot of hospital man work going into trying to figure out who's been caring for those patients, what equipment has been shared between those patients, what staff has been in and out. It is a logistical nightmare. So it's a lot more than just screening.
Exactly. I think it's a lot more than screening. And thank you for actually bringing in the equipment, because prior to this, like if you have to do a retrospective analysis on a positive clinical case, what equipment was shared? Like X-rays, CT scans, ultrasounds,
bladder scanner,
blood
glucose
pressure,
machines.
like what else is shared? It's an enormous challenge. So when we started looking at like improving the process, we also what we do is confirm clean of every product that is used or every room that's used, which is we glow germ or do ATP testing of the room after it's cleaned, just to make sure the cleaning is adequate and completed. So there's a lot of process that we do for the CRs, and a lot of work. And with this preemptive kind of analysis, we have eliminated pretty much about 90% of the work we were doing beforehand. So it's a huge achievement in what we were able to do. And thinking about the hospital itself, it's about 200-bed hospital with almost like 95% occupancy almost always. It's a logistical nightmare if we have to kind of block rooms for a long time. So just to be efficient, I think there's a lot of kind of processes that were placed to get into that mindset of doing it preemptively.
I think there's a lot about this specific, especially when you don't have a whole lot of literature. There's just a lot that goes into not just prevention, but once, like I said before, once a bug has gotten ahead of you like this, it's very hard to pull it back in, to rein it back in.
That's so true. I just wanted to speak a little bit about that, is that if you find a clinical case, it's almost in a unit, in our experience, it's certainly possible you'll find several other positive cases in the same unit. And like, so it really, as you said, like if there is like the bug, like it spreads. So what we have in our experience, Candida auris spreads very, very quickly between people. And like it sticks to the surfaces, to the walls, to everywhere. And it really, as you mentioned, it's a logistical challenge to get ahead of the bug at that time. So, right, our study kind of tried to stay ahead of it.
Stay ahead of it, indeed. And speaking of staying ahead of it, let's talk about communication with other facilities, too, to help everybody else stay ahead of it. You've got to, I don't know what your all's approach was, but were you communicating with facilities that you were sending the patients out to? Were you communicating with the facilities that you received the patients from when you received a positive screen? Tell us what that looked like.
Sure. So yes, we definitely communicated with the facilities that we received the patients from. As soon as we find out that they're positive, we call the facilities and, make sure that they're aware. Because we're also, once we find new positive cases, we are also required to communicate that to the state health department. And so with that, we always wanted to call the sending facilities first, just to make them aware, because then they're probably going to get a follow-up phone call once we send this report. So they might want to try to start doing their own look back and be prepared, because investigation is going to have to be done on their front. So we have a list of the local facilities around us, and strong collaboration with the Department of Health as far as communicating with these facilities. And upon discharge, then that's the same sort of process. The social work would communicate the status to the facility, and they would have to find the appropriate bed now, given their new status, which sometimes could create issues, because they might not have been on isolation before, and now they require a higher level of contact precautions. So, but it is becoming more of a thing, at least in New York City area, that many facilities are able to accommodate, but it can sometimes be a challenge because now they have a new status, and it makes their bed management of wherever they're going a little bit more complicated.
So you mentioned some involvement with the state health department. Can you talk a little bit about what that collaboration looked like?
Yeah, well, in this case, for this study, we didn't really work with the state directly per se, but as Karen had mentioned, anytime that we do get a positive colonization case, or if there happens to be an unfortunate clinical case, we do work really closely with our state Department of Health colleagues to follow up and do an investigation to see how far we need to trace back and what measures we need to do moving forward in that sense. So we look forward to kind of working with them more and more as this becomes a bigger issue across the state and across the country, I guess.
Well, that's an interesting way to put it, Erin. You look forward to working with them as it becomes a bigger issue. Like, yes, but we do enjoy collaborating with our state health departments. Go ahead.
One thing I would add to what Erin said is, like, I think the bigger challenge occurred when we identified cases from facilities who did not, one, knew about the case. So we had a person coming from a nursing home and they never knew and they never had a CRS case. And then we identified a CRS case upon admission. That became almost an educational opportunity for that nursing home. Some actually were very worried, why are we doing this test? And there were several times that myself, Karen, or Aaron had to communicate with the nursing home, explaining exactly why we're doing this screening. And that kind of helped them understand and provide us with the support that we needed in this situation. So it was a good collaboration, I would say.
Yeah, and this sort of speaks to an issue, sort of a broader issue, which is we don't know what we don't know. And I'm sure there are patients who have been screened or have had positive cultures for Candida auris that travel through different healthcare facilities without those healthcare facilities having any knowledge of positive test, because we don't share the same electronic medical records, or maybe some time has passed and that facility doesn't know that they're at a new facility. So I'm wondering what the future will look like as far as how we'll be better able to communicate and know when patients have actually had a positive test, so that we can apply whatever precautions we need to at our facilities.
I think that's a really good point, actually. I think in an ideal world, having a universal EMR that kind of speaks to everybody as the patient travels through these different kind of healthcare facilities would be fantastic. And I think in our case here, to a certain degree, we are able to see if they do have a similar EMR. We have been able to identify certain infections and cases from that, but also like combing through nursing home documentation when the patient comes to us. We've identified patients that way also, but in an ideal world, I'd love an EMR that just kind of spreads across everything.
Yeah, I agree. I think this is definitely something that we will need to address in the future, because to your point, Erin, I expect that this will become a much bigger problem as time progresses and we're seeing more cases. So just to get to the two study phases, can you walk us through what those phases entailed and the key takeaways from each of those? And was there anything that was surprising?
Yeah, this is it's kind of like the meat of the article. I know when people pick up an article, they always like to go straight to the results and see what had happened. So I think in our case here, looking at from phase one was our limited, very much a smaller subset, looking at specific skilled nursing facilities and specifically patients that had they were mechanically ventilated or had a tracheostomy. So a very small pool of patients that we were screening previously. And then moving on to phase two, when we opened up that screening program to cover all nursing homes with that kind of two-tiered approach where we had a high-risk group and a low-risk group to really manage that patient throughput, as we've all been talking about within our facility. I think those are the two kind of clear distinctions between the two. And as a numbers guy, I like to look back at this, and we tested 34 patients in phase 1, but we tested 557 patients in phase 2. So that's almost 16 times more tests. It's a lot of tests, a lot of swabs. I know a lot of the nurses tell us about, oh man, you're asking me to do another swab, but we're doing a really good job, because in this case, in phase 2, we identified 12 more positives. And of those 12 positives, 8 of those patients we wouldn't have caught if we had just kept our previous criteria from phase 1. So those are 8 patients that could have gone undetected throughout the hospital, all those movements and procedures potentially spreading C. auris across the facility.
That hit on something that I wanted to mention, because you mentioned screening beyond those traditional risk factors to enhance detection. Because, just relying solely on the usual suspects, that might miss a lot of cases.
Exactly. And as you speak of that, 5 of those patients were patients that weren't trached or vented. So we wouldn't have known about, we wouldn't have even thought about it if we hadn't expanded the screening in that sense. So that's it's a good pickup on our end. And we've still continued to see more cases now, I think, given the prevalence of Candida auris in our community.
Yep.
So
I just wanted to add too that, although we did, write about this as like a study, because we realized we had the cases and the timeframes were clear, we continue this process to this day. And, it really helps us to manage these patients better and prevent outbreaks in our facility.
Yeah, and it's not just preventing, outbreaks. We kind of highlighted the importance of early identification earlier, and that lowers all of the healthcare burden. It's hard to quantify it. I don't know if you can, but you're reducing all of that manpower that goes into the control. You're on the prevention part, and then you get to the control part, and there's lab workload, staff burden, financial costs to all of that. So great job, guys. Great job. And
I think just to point it out, I think it's a pat on our back here, actually. But we didn't have, of those 8 patients that weren't part of that criteria in phase 2, there were no positive roommates from any of that testing. So we really were able to identify these patients early, and we prevented potential spread.
I think Aaron, you're really highlighting a great point that I think early detection has helped us. And I think one of the issues that we initially faced when we were having clinical cases and all that was that we had to destroy supplies. There was a lot of expense with that. So as Nikki, you were asking about the expense, when we were talking with our leadership in the hospital, they were concerned about the expense of the testing, but also it was really easily offset by the savings that we were able to do by not decommissioning X-ray machine for a while, by not destroying or eliminating supplies that might have been exposed. So I think that on the balance, we kind of are ahead in that situation as well.
It sounds like there were a lot of insights gained from this experience. Can you talk a little bit about the lessons that you learned that could be applied to other multi-drug resistant organisms with similar transmission risks? Is this something that we can use as a blueprint for tackling other superbugs? Any thoughts on that?
Yes. So I'll start. I think the template. This is a template, and it can be used for other superbugs or other issues. But this is infection prevention 101. So you do scientific evaluation of the situation, and then you conduct some experiment, which we did doing the screening in this case, and then in the end you kind of look at the results, which we did, and we compared, and we were able to reduce the spread, and as Aaron mentioned, to other patients, which in turn is a happy place for us to be in. Now, that said, the study in our situation is based on higher than usual prevalence of C. auris in our hospital or surrounding in the nursing homes or overall in New York State. and then the situation in the hospital itself, where our mix of patients there's a higher than normal mix of patients coming from nursing home. And I think third, an important thing about that really is that we have had several years of experience in this. With this, when you say to apply this to another bug or another superbug with modifications, yes, but this situation specifically is for CRs or Candida auris itself, which is a specific kind of organism. I think we can definitely adopt similar protocols or early screening as we can, and we should be doing for certain CRE or carbapenemase resistant enterococci. We can, sorry, wrongly, CREs or carbapenem resistant enterobacteriaceae. It's important for us to remember that the epidemiology, the prevalence, and the incidence of these organisms need to be accounted for every intervention we do, and as we always do.
You know, guys, this has been very helpful. I hope so for our listeners as well. And I just want to thank you guys so much for sharing all your insights with us today. It's been very informative and maybe slightly less terrifying than we initially anticipated.
Thanks for having us. This was great. And I'm just glad that, people are interested in our work.
Absolutely.
And a big thank you to our listeners. Remember, hand hygiene is your best friend. And maybe invest in some good quality disinfectant wipes.
Well, until next time, my friends, stay safe, stay healthy, stay tuned for more infection prevention adventures. And that is a wrap. Bum-ba-bum. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.